It is, as the name indicates, emerging options in the treatment of inflammatory bowel disease. So there are three parts to this lecture. Not all of them are very long to make you feel more comfortable. The first is a brief overview of inflammatory bowel disease. The second is what are the current treatment options and their limitations. And the most important is what are the emerging options and what does the future hold for us as far as the treatment of inflammatory bowel disease goes. Now, as I can see, there are a lot of postgraduates as well in the audience, so it is a little bit of an odd mix for physicians and postgraduates. But we'll try and discuss as much as possible in the time which has been allotted. So basically, as the name indicates, inflammatory bowel disease means inflammation in the gastrointestinal tract. It depends on which organ is involved and how extensively it is involved and how much across the wall of the intestine it is involved. So generally, if you look at it, ulcerative colitis will involve the colon, while Crohn's disease will involve any part of the gastrointestinal tract. About whether it is through the breadth of the mucosa or not, ulcerative colitis is a mucosal disease, whereas Crohn's disease is a transmural disease, so the whole wall of the intestine is involved. Needless to say that the complications of the two are different. In Crohn's disease, because the full wall is involved, you can have abscesses adjacent to the intestinal wall, and you can have fistula and so on. There are certain variants which we have not mentioned here, which is the middle capsule-like figure which you can see, and these are like indeterminate colitis and so on. So basically you have two broad groups, and like it was said in the introduction, it is no longer a disease of the West, and we see plenty of patients who have this difficult problem, which is difficult to handle not only for the physicians who are treating them, but more so for the patients who are suffering from them. To go into the manifestations of ulcerative colitis and inflammatory bowel disease, basically there are interstitial symptoms and extraintestinal symptoms. These are all well known to everybody who is attending this meeting. This can be of interest to people who deal with like branches like rheumatology, or for that matter ophthalmologists, or for skin and dermatology doctors. So if they are seeing people who have one of these complications which are listed here, it could ring a bell and suggest that there could be inflammatory bowel disease in these patients. So basically you have interstitial manifestations and extraintestinal manifestations. Now there are various ways in which you can diagnose these, and basically you start with symptoms, clinical history. You can do a physical examination. Not much is gained by doing a physical examination in people with inflammatory bowel disease. In laboratory tests, you have the standard blood tests. Of these, of note is the C-reactive protein. What is not mentioned here and which we of late have been doing is the fecal calprotectin test, which is readily available. In imaging, what has emerged newly is the use of CT enterography and MR enterography. And finally, of course, the sine qua non of diagnosis is the symptoms and what you find on endoscopy. As of now, I think there are very few people who do only a sigmoidoscopy. In most patients, we would do a full colonoscopy, unless, of course, you suspect that it's a very severe disease, which is not going to be very good idea to do a full colonoscopy. Actually, if you look at the pathophysiology, it is a very complex issue, and it is beyond the understanding of most of the clinicians, including myself. And you have a mucosal immune system in the healthy state, and there are two aspects to it. One is the pro-inflammatory mediators, and the second is the anti-inflammatory mediators. And as you can see here, they have struck a nice balance, and that is why the person remains healthy. And that is, his bowel remains healthy and he is symptom-free. For some reason, either it could be some underlying genetic factor, or it can be a host factor, or it can be an environmental factor trigger, such as the microbiome, change in the microbiome, or so on. You can have a tipping of this balance in favor of pro-inflammatory mediators and a decrease in the anti-inflammatory mediators, and this ultimately leads to mucosal inflammation, leading to Crohn's disease or ulcerative colitis. Now there are various phases in which this disease occurs, and this slide shows the two important phases. The first is the vascular phase, where there are a lot of things happening in the blood vessels. And this then goes on into the intestinal wall phase, where all the thing which happens or all the abnormalities which take place in the vascular phase, they go out of the vascular wall, enter the intestine, and then there they release cytokines and so on, and lead to signs and symptoms of inflammatory bowel disease. Now this is a complex slide, but what we have tried to show here is that if one is trying to speak of pathophysiology of ulcerative colitis or pathogenesis, these are various aspects which people have been working on, and I don't think I have even counted how many are there on the slide, but there are plenty of ways of looking at this disease and plenty of abnormalities which can occur in an individual patient. There are some which have really translated from a pathogenic standpoint into a therapeutic standpoint. If you look at the cells which are involved in inflammatory bowel disease, they are generally not polymorphonuclear leukocytes, but they are basically lymphocytes. Now, if you look at the blood flow in the body, you realize that the blood flows at an amazingly fast rate. I don't know how much it is, maybe the cardiologists might be able to say. But suppose you assume that there is a vascular wall and there is blood flowing through it. Outside the vascular wall, there is something which the leukocyte or the lymphocyte feels it should pay attention to. By the time it pays attention, it would have gone ahead. So there are mechanisms by which the lymphocyte recognizes that there is something going wrong, and at the same time, there is something like a speed breaker which you have on the road, which can sort of slow down that lymphocyte so that it remains in that area and does various things and eventually goes out of the intestinal wall and leads to an effective mechanism to prevent any abnormality. Unfortunately, this happens at the wrong time and at the wrong place. So the lymphocytes migrate when they should not really be migrating, and that leads to an inflammation and inflammatory bowel disease. Now, people have spent their lives looking at all these various aspects like tethering, rolling, firm adhesion, transmigration, and eventually migration. And they have tried to find out how this thing actually occurs in the body and translated into some newer molecules which have come in clinical trials. Some of them are expected shortly in India. In the intestinal phase, what happens is now once these cells have transgressed through the intestinal wall, they go into the outside area, and this basically leads to the key factor, that is nuclear factor kappa beta activation, and this leads to a burst of various cytokines, and these lead to inflammation in inflammatory bowel disease. What research workers have tried to do is to focus on each of these steps and try to develop certain agents which can be beneficial to treat these patients. One of the important endpoint of a lot of these treatments is inhibition of the NF-kB pathway, so that ultimately is one of the final common pathways. Like you have the HK-ATPase pump in acid generation. So this is in brief what happens actually. So if you have an inflammatory stimulus like TNF-alpha, you have this inactive NF-kB in the cell and cytoplasm. What happens is it migrates into the nucleus, and in the nucleus it leads to generation of various mechanisms by which you have a release of pro-inflammatory cytokines from the cell, and this ultimately leads to an aggravation of the inflammation. Various treatment options which we use today in practice, there are two approaches in general. So once you have diagnosed, like I said in the beginning, this lecture is not how you diagnose and which tests you do and how you do them in which patients. It is mainly focused on emerging aspects, so that is why this introduction to this topic. There are two ways in which you can treat inflammatory bowel disease. One is what is called as a top-down approach. Here what you do is you don't wait for the person, you don't wait to start drugs one after the other. You start with the most strong drug and then you come down to the lower drugs. This is called as a top-down approach. So this is not very commonly practiced in India, but in the US there are many centers which practice this approach. What we generally do here is a top-up approach. So we start with a milder agent. If the person does not respond to sulfasalazine or 5-amino amino-salicylic acid. We go on to a steroid. If that does not work, we add an azathioprine or 6-MP. Then we can go on to biologic agents, and then of course, if everything fails, consider surgery. There are a lot of limitations of individual current agents. So if you look at this top-up approach, which we just discussed, you have a cornerstone of treatment in the form of 5-amino-salicylic acid. This has various side effects such as hypersensitivity. Sometimes you can have effects on the kidney. Hair fall is a very common symptom which we encounter. Corticosteroids, we need not discuss the side effects here, they are well known to all of us. Methotrexate has its own problems, and the new kid on the block, which we have in fact been using for the last 8 to 10 years, is anti-TNF molecules, which are all monoclonal antibodies. The most important side effects which we have to fear of in the Indian circumstance is activation of hepatitis B and activation of tuberculosis. And before starting any patients on anti-TNF, we always make sure that we have ruled out quiescent diseases of hepatitis B or tuberculosis. A little word about TNF biologics. As all of us know, there is a standard nomenclature for all these antibodies, and if you look at infliximab, it is you have the human portion and it's a chimeric antibody. If you have adalimumab, which is recently introduced in the Indian market, you have mainly a human monoclonal antibody. And this is actually an interesting molecule because these two have the ability to cross the placental barrier. So if you are using it in a pregnant lady, it's not recommended. Here what is done is you have this polyethylene glycol molecule, and these two active ends are kind of packed in the polyethylene glycol molecule. Because of the PEG, this does not enter the placenta, and the baby remains safe and we can use it in pregnancy. This of course is not available in India, and I have no experience with it. Like I said, one of the problems, we have been using TNF agents for almost 10 years, and there are certain problems. One is, of course, we don't use it if you are going to suspect that tuberculosis is going to get flared. But you have a big problem of non-response in what you do to these patients when the person does not respond, because that is like the most powerful weapon in your armamentarium, medical armamentarium which you are using. So there are various things which you can do about these patients, and these are put very simplistically in this slide. But basically you have to remember that you can have antibodies developing against these monoclonal antibodies, and then you have to think of what you can do for these patients. So one of the options is you can switch to another anti-TNF agent, or you can switch on to newer modality of treatment. Like I said some time back, if you have this issue of how the lymphocytes migrate, if you look at the leukocyte cell as such, you have these integrins which are attached to the leukocyte, and you have these adhesins which are on the other side. So you have a combination of these integrins getting in contact with adhesins, and then you have these two coming together. There are various types of adhesins which you have, and you have this VCAM which is all throughout the body on the vascular endothelium, including the central nervous system. One of the earliest molecules which was introduced was natalizumab. So about 4 or 6 years ago, I think it was very widely discussed in the Digestive Disease Week in the US, and it was considered as a very remarkable molecule for treatment of inflammatory bowel disease. Unfortunately, like I said, this VCAM to which it attaches is present throughout the body, including the central nervous system. And that is why there were a lot of cases with PML, or progressive multifocal leukoencephalopathy, which occurred with the use of this molecule. And like I said, there are people who spend their lives doing all this research, and they found that you can have a leukocyte which has the similar integrins, but it joins only to this MADCAM, as it is called. Although the name is MADCAM, this molecule makes a lot of sense because this is a very GI specific. So this adhesin, which is called as MADCAM, this is there only on the cells in the GI tract. So this is called as vedolizumab, and in 2014 there were 2 very landmark trials in New England on this molecule, and which kind of took the IBD fraternity by storm. Like I said, these are the two molecules which have been recently introduced. Neither of these is still available in India, and I think it would be very helpful if a company like Cadila Pharmaceuticals takes a lead in developing a biosimilar for this molecule. One of the main attractions of using these molecules is that they can be used as first line, they can be used in people who have not responded to the earlier first line, and more specifically, unlike TNF-alpha inhibitors, these generally act specifically on the GI tract. So this is an important advance which we have seen as an emerging option, and I think within 2 or 3 years we may have this molecule available in India for use for our patients. There are a lot of people who do not respond to all this, so these are the groups where you can the Society of Gastroenterology in America, which is a leading society, is called as the American Gastroenterology Association for non-gastroenterologists. And they publish 2 journals, one is Clinical Gastroenterology and Hepatology, and second is Gastroenterology. So the last, I think it was in July, August, when the issue came to my office, there was a cover page which had curcumin, which is haldi in India, as a cover picture, and I said, what is this picture on CGH? And when I opened, I found that there was a trial on curcumin, role of curcumin in inflammatory bowel disease as a lead story. So curcumin is an Indian drug, and some time back there was some discussion by Dr. Adkar on innovations and how you can put to use drugs which are already available. So curcumin is a so-called medicinal dietary component which we take day in and day out in the Indian diet, and it has various properties like anti-inflammatory, antioxidant, anti-proliferative and anti-angiogenic. So basically what it does is, we just saw how this NF-κB acts and leads to a generation of pro-inflammatory cytokines, and actually if you look at the way curcumin acts is by preventing all the 3 steps in this model of NF-κB activation and subsequent release of TNF. So what we are doing by way of targeting the TNF with all these fancy drugs, with curcumin you start kind of at the beginning point, and that is why all these downstream events are automatically prevented. There are various sites of actions which people have studied in inflammatory bowel disease. There have been 1 or 2 trials, and this the one which I mentioned, I think about 4 or 6 months in CGH, the lower reference which you can see. There what they did was they gave about 1 gram twice a day of curcumin to patients with inflammatory bowel disease. Of course, this was not a trial on active disease, so these people were patients who had gone into remission after treatment. They gave 1 gram twice daily along with mesalamine to a group of about 40-50 patients, and they gave only mesalamine to about 40 or 50 patients, and they found that the relapse rate was much lower in the curcumin added group as compared to the 5-ASA or mesalamine group. So the clinical, I think the endpoint was at about 6 months. At 6 months, they found that the relapse rate in the curcumin group was much lower than if you did not act. So it is again, it should be an endeavor on part of Cadila Pharmaceuticals probably to get this molecule. Now, I was checking at home as to how much curcumin one may be using in our day-to-day cooking, and it is just at the tip of a small spoon. And the dose used over here is about 1 gram twice a day. So there has to be some ways and means in which you can take a small dose and yet have a good effect. And to this effect, there have been certain improvements in the methods of delivery of curcumin, and this I think may be a research molecule from Cadila in the pipeline, where they have this SMEDDS technology, which is self-microemulsifying drug delivery system. And with this, what happens is, even if you give a very small amount of curcumin, like what you normally take in the diet, its effect can be enhanced kind of, and you can have an effect which is similar to the 1 gram twice a day, which is generally mentioned in the study. So this is another thing which holds promise for the future. There are various other newer agents which have been tried, and of this, we won't go into all of these because it is part of it is really beyond my understanding as well. But there has been a flurry of investigations and reports on plasma exchange, plasmapheresis, then genus kinase inhibitors, and so on and so forth. As of today, if you look at the paradigm of management of inflammatory bowel disease for practicing physicians, what we do in practice is we first make sure that the person has inflammatory bowel disease. We decide whether it is Crohn's disease or ulcerative colitis. Then we decide what is the extent of the disease, whether the left side of the colon is involved or the whole colon is involved. Depending on that, you can decide which medicine you want to use, meaning if it is a left-sided disease, you can use a rectal formulation. If it is a pancolitis, you can use an oral or an intravenous formulation. The other thing you have to do is to decide which molecule you are going to use. As of today, not many gastroenterologists in India are starting with TNF-alpha inhibitors because of various reasons. We start with the step-up approach and not the top-down approach. But we do use a lot of TNF-alpha inhibitors in practice. Maybe not as much as our rheumatology colleagues do for rheumatoid arthritis, but pretty much in a lot of patients we use these molecules. So what we tried to do today was actually not a standard lecture on inflammatory bowel disease, which is generally given in PG forums and CMEs and national meetings, but to only discuss what are the emerging options and which have been recently described in the treatment of ulcerative colitis. So with this talk, I would like to thank all of you for patient hearing.